Hello, and welcome to another edition of the Scenic View podcast. I'm your host, Jonathan Owens, along with Suzanne Beasley and Artis Watkins, our executive director. Today we have a full studio in here because it's a very important episode. It's a recap of the State Health Plan Board of Trustees meeting with State Treasurer Brad Briner and Plan Executive Administrator Thomas Friedman. Welcome, you folks.
Hello. Pleasure to be here.
You are the two men at the center of some of the most significant changes in health benefits for state employees recently. On Friday, the board voted to raise premiums for most of the plan's 750,000 members, approved a sweeping overhaul of how the plan pays for care through provider network tiers, and voted to return to Blue Cross Blue Shield of North Carolina as the third-party administrator in 2028.
And the pharmacy benefit manager.
And the pharmacy benefit manager. And we'll get into that. These decisions will affect every state employee, teacher, retiree, and their family, about 10% of the state's insured population. So before we jump into the plan, Treasurer Briner, what are your thoughts, I guess, first?
Sure. This journey began with a healthcare system that is troublesome for everybody involved. And we all know that. We all live that. It doesn't matter if you're on the state health plan or not. Everyone's got the same experience. Prices keep going up faster than you have money to pay for it. And there's a lot of reasons for that. As an aside, the governor asked me to co-chair State Healthcare Affordability Task Force. And I'm doing that with Secretary Sangvi to try to figure out if there are ways we can help solve the broader systems problems. That's a much harder challenge than solving the state health plan's problems. Today, we're going to talk about the state health plan. We've got real challenges as a country, as a state, in our healthcare system. We can't solve those by ourselves, but we can solve a lot with a state health plan. And that's what the board meeting was about on Friday. Mm-hmm. We can take control of our state health plan in ways we haven't before, use kind of basic market principles and certainly the scale of the plan to drive a better bargain for everyone involved in the plan. And then we can reward our members for helping us do that.
Right.
So that's the basic architecture that we want to do. It involves change. We understand that change is hard in every walk of life, but in healthcare particularly. We got a lot of people who are in the middle of a challenging care journey, and we don't want to make them change. So there are a lot of things that we're going to do to protect people who shouldn't have to bear the brunt of change. That said, we are going to ask people and we're going to reward people to change providers in certain instances. We'll talk about the different tiers and we'll talk about what we're doing there, but it revolves around a basic concept. There are providers who really want to work with state employees, and they value who they are and they value how many of them there are.
Yeah.
They are high quality providers. They will enter into direct contracts with us at lower rates. What we need to have is our members to go there. That's the essence of the bargain. There's a lot of detail behind that, but remember over and over again, that's what we're trying to do. Why do the providers want to do that? Because they can get more volume. Mm. And so in places in the state where there's one provider and they have all the volume, they can't get more volume. They're not likely to enter into a contract with us to lower rate because they can't make up for it with more. So wherever you are in the state, if you don't have competing healthcare providers, most likely everything's going to be in the access tier, which means prices don't go up. They stay flat year over year. Where you have a competitive healthcare system, and that's certainly the Triangle, the Triad, and certainly Charlotte, we can go to providers with this bargain. And many of them have stepped up and excited to talk about that.
Well, without naming any names, there are systems right now that are seeking to limit competition even in the areas where it currently exists.
Yes.
Are you worried that this unchecked consolidation, no matter who the players are, and they've been all over the board in terms of the players, will simply leave you without an ability to exercise your largeness as a system to extract that kind of competitive nature?
It is a totally fair question, but there's so many other pieces to it that are to some degree in play, certificate of need being one of them, where you're starting to see around the edges, the certificate of need paradigm change in North Carolina. 2-3 years ago, a couple things came out. This year, another element came out. And so you've started to empower health systems to actually compete with each other, which really helps get at the core of what you're asking about. To the extent we refuse to let them compete, then consolidation is an enormous problem for every payer, not just the state health plan. because we see how that always works out. So there's two sides to this, very much in favor of competition. I think it helps us all be more efficient. It is uncomfortable often, but it's what makes for better outcomes over time. And so to the extent we can get to a competitive market, that's going to be better for everyone, however we get there.
And I know you're here to talk about the state health plan specifically, but because you mentioned the Commission on Affordability,
Sure.
We have feelings about that because we've watched different iterations of that over the past few governors. And every time we see the appointees, not of the voting members, but of those who are, I can't remember what they call the rest of the folks who are advisory members, the folks from whom you, like all the other committees before you, will be taking advice are largely the ones who are part of entities that caused us to be number one in cost in the nation in the first place. So why would any person out there think that it's going to be different?
It's a totally fair question. And we will have our inaugural meeting here at the end of July. The temptation is going to be to address a handful of well-trod paths of how do we create marginally better outcomes in certain areas. I think that is valid territory, but more interesting to me is a reimagining of the healthcare system that would actually work. There's probably two real visions for that globally. And so we've actually asked the folks who are doing some of the underlying consulting work to start those work streams as well. I actually have in my office a Commission on Affordability from 1977 study.
Oh, my goodness.
And 80% of it could be written today.
Right.
So these challenges are not new. You're right. Many commissions have tried. I hope that by having more ambition than others in terms of looking at the broader system, we might be able to at least present a vision of how things can work. Getting from here to there, huge challenge. But at least knowing where you're headed, you can start doing things that get you closer to it.
Got it.
So our members have a lot of questions. We did post on our Facebook page a few times over the weekend. And if you guys didn't know it, we have the most active Facebook page in all of state politics. That's just me making that proclamation.
I was like, based on what? The metrics of what?
No, I'm standing by that
when
one.
you do that,
and I'm standing with John.
To quote George Costanza, it's not a lie if you believe it.
That's right. And I challenge any organization to top us because anytime we post,
they can top us. They just say, just topped you,
or just show us the metrics. But no, we did post several times over the weekend about the changes to the plan, and we got more than 500 comments and lots of questions. And so we're going to kind of base this whole interview over what we saw on the Facebook page. But before we dive into them, I kind of want to veer off course a little bit. And this is something that came up a lot over the weekend on the Facebook. So I'm not ignoring those questions, but it seemed with our members, the tier system seemed to be the most confusing part for them. And I know, Thomas, you released a video yesterday that was kind of clearing up some of those, and I thought it was very well put together. So I thought
I'll credit to Loretta.
So I thought it had a great explanation of the whole thing. So I wanted to kind of start with that. UNC Health, Novant, and Iredell I always say Iredell wrong, right?
Ardell.
She gets on to me every time.
Depends where in North Carolina you're from.
Yeah, true.
Yeah, I'm from Moore County, so we say everything kind of weird. But Iredell, Novant, and UNC Health are preferred providers, whereas Atrium and some Duke specialized.
Duke LifePoint, very different.
Duke LifePoint, okay, are non-preferred. And members are asking about Cone Health, Caramont, ECU Health, what do I do down east, things like that. So can you just kind of start with explaining the networks and how all of those are still in network?
Sure. Yeah, I think that's a really good question. And I think the most important starting point for me is most healthcare providers in North Carolina are in the access tier. So there's 3 tiers. There's preferred, access, non-preferred. Access is most providers in North Carolina, right? So I think you did a good job of summarizing the preferred health system and some of the non-preferred. That means everyone else is access, and I'll qualify that in a second. But so most providers are access, and that is the benefit you have today with one kind of big exception is we've reduced the copay to use specialists. Want to make sure there's access to those things. Heard loud and clear the specialist copay is too high now. And so we are using some of the savings for the preferred provider structure to pay for copay reductions in the access tier. Something also really important. So we've had a lot of preferred providers for a long time. We are just enhancing that benefit across the board. So yes, from a health systems point of view, UNC Health, Novant Health, Ardell Health. But also we have 4,500 primary care providers in that tier, 6 multidisciplinary specialty practices, Wilmington Health, Tryon Health, Eagle Physicians, Piedmont Health, and then ambulatory surgery centers and other surgical places like Emerge Ortho, Ortho Carolina, Pinehurst Surgical. So while we have added health systems, what we have done is effectively added to a structure and made the benefits more attractive across the board in that structure. So right now, if you went to Emerge Ortho, your specialty copay is the preferred tier. Next year, any service you get there is at the preferred tier. Any service at Tryon Physicians in the Charlotte area. So they have orthopedists, they have specialists. Any service you have there is in the preferred tier. So I think the health systems rightfully got a lot of attention because that's where the spend is in healthcare. But most providers, 85-90% of providers in North Carolina, just based on numbers, are in that access tier. So no one has gone out of network. We are still determining who is that access provider in the triangle. We had thought it originally was going to be Wake Med. There have been recent developments that people want state employees' business more and more and are willing to cut rates to stay in at that access tier to get things. And I think, to where the treasurer started, this is about competing for your business and giving state employees better prices for things.
Listening to you about the different networks, it's almost kind of like you're bringing the Lantern program to the whole plan. Is that
it's a very smart framework to think about it, right? For a long time, I think we have all agreed healthcare is too expensive and healthcare prices are opaque and we get charged too much to pay for things.
Mm-hmm.
One of the beauties of Lantern was we negotiate through scale to get lower cost. The member has to save first. There has to be high quality providers. And, we're kind of doing that on steroids a little bit. I think about if you're going to use a preferred provider, whether it be a primary care provider or a health system, those are folks that have agreed contractually to provide better value for our members and their care. So you could pay $250 for a service somewhere, or you could pay $150 with the preferred provider. The more people that choose that $150 path, the lower premium costs are going forward. And the members got to save first, or this is a meaningless exercise. And I think bringing in 2 large health systems that cover, go from Avery County to Brunswick County gives the most members the most opportunity to work with the health systems that really want to work with them and provide that value and discount to our members.
Can you explain a little bit about how those systems were chosen for the different tiers? Or were they chosen, or did they just sign on?
Yeah, no, I think it's a good question. I think starting in the fall, we had some communications with the health systems in partnership with the Healthcare Association when we started the Lantern program and kind of first articulating the treasurer's vision of healthcare is too expensive and you need to compete for our business. State employees are valuable. You need to compete for our business. We said kind of then and there, folks that want to go on the surgical journey with us are the first folks we're going to talk to from a partnership point of view for the rest of us. Because it is confusing. It's like, go here for this, but go there for that. People have so much bandwidth.
But you had to start somewhere.
You had to start, right? Then treasurer and I, and then me kind of separately met with the heads of every health system and be like, y'all, we're not kidding. The prices have to come down.
Did they say that's cute?
One of them who wasn't picked, I think, thought it was a little cuter than everyone else did. And I think you can guess who they are and where they sit today. But,
you did ask some of these folks, just, you need to compete for our business.
Yeah.
And the reaction to that in certain cases was, don't you understand we're not in the competition business?
100%. That's
appreciated the
how
candor.
they feel. They're very open about it. Their lobbyists are very open about it in the building.
Yeah. Well, and then so, you have those conversations and kind of go back to something. I'm not going to beg you to give us a good deal and work with us. But UNC and Novant saw the vision right away and said, we do want more state employees. We want more teachers on the plan. Let's figure out a discount that works well for both sides so we can do richer benefits for members and lower the prices across the board. And they've done some pretty substantial price lowering across the board. And that's reflected in the benefit differential, right? If we're making the benefit half as expensive as the access tier, that is who's paying for that. UNC is paying for that. Novant is paying for that. Merge Ortho is paying for that on behalf of members. And then I think the beauty and the elegance of it is the member saves at the point of care. And then we, on the back end, spend less money so that the rest of the members, I'm assuming we're going to talk about premiums at a point in time here, that our cost goes up less and there's more money to keep premiums low, more money for salary increases, more money for COLAs, because we don't need as much money going forward, because it is one pool of money. And so my job is to make that the need from the health plan on behalf of the taxpayer, the members, and everyone as low as they possibly can while maintaining that high level and high quality of care. And Novant, UNC got it and they stepped up. And later this week, someone else is going to have stepped up and really been interested in helping us reduce our costs.
That back end part of the plan is a link that I think that our folks don't understand too, that the sustainability of the state health plan is, quite frankly, in jeopardy. So something has to change. So yeah, I appreciate you just trying to clear that.
It's complicated and digesting it all at once is really, really hard. And that's why we need to do things like this. And we, credit to Bertie Bland, who's a scenic member out in the western part of the state. She's already reached out and said, "Hey, you got to come back out here and talk to all of us." Because we were out there in Morganton, I don't know, in the fall.
Oh, okay.
And she's like, "Hey, you got to come back out here and talk about this again." I was like, "I'll be wherever y'all want me to be." I'm meeting with District 61 and 62 first week of August.
Down east,
yeah. So I will be wherever y'all want me to be. One, I fully acknowledge this is complicated, but it is complicated because healthcare is complicated, and this is the only way to make it more affordable for those who can use it and have money on the back end so we don't continually need to use more and more resources that pulls resources from everything else.
And I think some people listening will have no idea. If they're newer employees, they have no idea the history of the health plan. When I started at Scenic in the dark ages, one of the first things I was reading about was that in the late 90s, after Hurricane Floyd came through, state health plan reserves were literally used with Hurricane Floyd relief. That struck me as extraordinarily odd. But what really struck me as odd is that when the health plan would be used in these the retirement system in 2001, the funds were escrowed by Governor Easley at the time. We had to sue to get those put back. Money would just get taken like it was going to get taken just for a minute, but it wouldn't make its way back to these systems. And so there was sort of this idea that the health plan, it's very ad hoc, obviously. We'll just throw whatever money we need at the time. And every time it ended up needing money, which, by the way, wasn't because the health plan members were somehow more chronically ill than the rest of the population. It was because of this mismanagement over the years. And this well precedes even me working at Scenic. This is just a thing with the health plan. But it was subsidizing, and we were told this back in the day by legislators. This is how we keep costs down, and that's how we keep care in rural areas in parts, is by having the health plan overpay. So y'all are just going to have to chill. That was never going to sit right. That makes no sense. That's a terrible system if you're having to subsidize in that way. But what we've seen is state employees literally told to our face, you're subsidizing stuff. And now when the legislature's having to put in more significant amounts of money, they're like, but look what we just did for you. Hello, not sitting legislators right now, but the legislative body created this for decades. And now they want to put the onus. It feels very much to state employees and retirees like it's put on them and not on the plan. So I get it that y'all can't do something that's super simple that would be easily understood, because that would have to be something just super drastic like the Clear Pricing Project would have been. And that was clearly met with an absolute no way, bipartisan no way. And by the way, that never shocks me either, because it's the most powerful lobby, honestly, in this state. And pretty much nationally, healthcare is the most powerful lobby because that's where all of our dollars are. They can afford to lobby. So I think, Treasurer Briner, when you were about to assume office and we had a conversation, one of the first time I ever sat down and talked to you, I know that healthcare was at the top of your mind.
Absolutely.
And it seemed like without even having gotten into the health plan deeply yet, you were aware that, oh my goodness, this is a tough one. Like the retirement system was going to be no sweat to you because that's your world. But can you kind of tell us how you decided as you were assuming office, this is how I'm going to approach healthcare, and How is that borne out, this second year into it with Thomas at the helm and the vision that you had, and I guess you two together have for the plan?
So I think it was 10 years ago, the first time, and Treasurer Falwell gets all the credit for this, the first time we actually understood the magnitude of the financial promises we made in the state health plan. They'd never measured them before.
Right.
And, it was $30-odd billion, and it was $35 billion by the time I came into office. And so that scale is just enormous. $507 million, a number we talked about a lot, and that was the projected deficit for 2026. That number's enormous in any one year. And so I think the first thing that as you go through these conversations and getting up to speed, the enormity of these numbers mean that no one alone can solve them, right? Everyone's going to have to join hands and figure out a way to solve them together. Two, the system is set up for the payers to fail, right? And that's what you see over and over again. Every year, more of GDP in this country goes towards healthcare, right? It's set up that way. And so we're fighting a big number on the one hand and a system that's somewhat broken on the other hand. And given those things, there's only so many strategies that could even possibly work.
Mm-hmm.
And one of them is the one we're pursuing. And that is to bring the resources we actually have in control, the scale of our members, the engagement of our members, the money we do have, the relative amount we pay to Medicaid, as an example, to bear on this problem that will age well. One of my favorite investment managers ever always would talk about when considering a situation, is time your enemy or is time your friend? And you always want to be in a situation where time is your friend, where if things normally just play out, things get better. That's the architecture we want to put in place, where people compete for our business. They learn that they need to compete for our business, and then they become more competitive next time. And in so doing, they become more efficient so that they can lower their costs and pass those discounts on to our members. So that's what we're trying to do, is set up a system that ages well, that gets better over time, that aligns incentives for everybody. We want our providers to be successful, right? We need them to want to be in these type of arrangements. Now, successful within certain limits, right?
Right. No, but we want and need them to make a profit.
Yeah.
We don't need them to subsidize every little league team there is. The communities would have more money to do that themselves if your county government and your city government weren't having to spend 1,000 times more on healthcare than they should. But we're with you.
Yeah.
They are not in business to be charities. That's not the way it's set up.
Right.
But for goodness sakes, it shouldn't be as profitable as Louis Vuitton or something.
Mm-hmm. As a guy who studied a lot of the financials over the course of my life, studying hospital financials is just fascinating. There's so many things that still don't make sense to me. The nonprofit distinction in the healthcare world is like no other nonprofit distinction. I used to work for a large nonprofit foundation, in fact, and that meant that we literally didn't make profits.
Right.
That is not what it means in healthcare. It means that they've struck a bargain with the state where they give more charity care and they pay less taxes. It has nothing to do with whether they're profitable or not. In fact, as you look around the state, you'll see that the large for-profit health systems are oftentimes less profitable than the not-for-profit ones, which is just,
and
again,
that the 990s show less charity care than is portrayed often. That's what blew my mind when we finally took time and looked at the 990s.
But some of them are doing more than you might think. And so it's not uniform.
Exactly.
And, we do have, and, we've talked about this a bit as it relates to the access tier. We do have two very different healthcare systems we're dealing with as a state. There's urban and there's rural. And those are very different challenges that need to be solved very differently.
And that's where some of the complication comes in, Thomas.
It is, right? Because again, you're trying to solve two very, very big, very, very unique problems for one set of folks, and trying to message it is where we're just a lot of work to do, right? Like, it is trying to be respectful and courteous of our members to understand, like, I've had some members like, hey, I really want to go to a preferred provider and help. I understand where you're coming from. There's just none around me. What should I do? They're thinking of it from like a systems point of view, and it's like, there's access providers. If you're traveling, like, we can try to think through things creatively together, but healthcare is inequitable in the state of North Carolina from where resources are distributed right now. Not something we can fix immediately. And that's why we needed a really big, robust access tier. And that's why we needed to invest in making the specialist copay cheaper, because we can't penalize people for their specialists in rural communities. That's not a reasonable proposition. And my job is to make sure there's more specialty providers in the preferred tier as time evolves, right? We want to be inclusive in terms of making sure there's independent providers, because there's not a health system in every county in North Carolina, but there are doctors. And to the extent we can align on values, pricing, quality, and access, we are going to expand the tent to get more providers in. But we started with primary care and behavioral health and surgeries because one's the quarterback, one's the most impactful. This year was really about where's the money, right? Where are the big dollars? And it's at, like y'all just talked about, it's at health systems. And then how do you grow it so we're all aligned on mission and value? And I think we've shown we're willing to be good partners. We're willing to pay it forward to the members first. Because if the member doesn't engage, this is
pointless.
This is a PhD thesis that no one's going to read at any point in time. And that's why we are so committed to making the benefit richer in the preferred tier, because we really got to show folks, these folks are valuing you. And I can't give anyone a $7,000 raise. I mean, I think maybe 50 people I can, plus or minus. But we can, for those sickest folks, drive down your healthcare costs by thousands of dollars a year. And Loretta schedules kind of talking sessions with me and state employees and teachers across state. We have a lot of, a good number of folks that are spending $10,000, $12,000, $13,000 a year on healthcare.
Yeah.
And shame on us if we don't try to make that number lower, because there are opportunities to do it. And that's where we're kind of targeting, is those folks that are getting just absolutely drilled. Like, to borrow a phrase from the treasurer, the healthcare safety net is broken. Our job is to make healthcare more affordable. And we're starting with our sickest members and our lowest income members. This is like sort of the target and framing. And then we got to continue to build up on that. And so that's really the goal and the intent of this, is how do you improve upon a system that's bankrupting people,
right,
that is inaccessible for a lot of people. But also we can make better with some behavior change. But I can't make people value state employees more. I can show the value. I can value them. I can fight for y'all every day. But some folks have different goals. I think there's a health system. It's like, we treat everyone the same. We want to look at everyone the same. Same. It's probably not the partner for us. The folks that say we want to see more state employees, we are willing to charge you less for those things. I got to run towards those people.
Right.
Yeah. So speaking of cost, and you brought this up earlier, let's talk about the premium increase.
Yeah.
And the headline out of the meeting, I guess it's the most eye-catching, was 5% increase for all.
Yeah.
And Loretta schooled me a little bit on that.
When we keep saying Loretta, y'all, it's Loretta Benini, who is the communications director for the treasurer's office, and who y'all would know that name. She came from Spectrum News. So she's in the room. We keep looking at her and saying her name. I just wanted to clarify that.
So, everyone sees that number and they're comparing it to the 3% pay increase they just got. I replied to a few comments and explained that those are not the same. That's not an apples to apples comparison. The 3% raise is much larger than a 5% premium increase,
Yeah. And just a couple things and like a brief venting. I think the headlines were pretty lazy, to be perfectly honest with you. But also I get it. Like, if you do 2 percentages, you're like, well, 5 is bigger than 3.
Right.
But we were, and we were trying to think about it more in dollars and kind of total cost of care of things, right?
Dollars per month.
Dollars per month is sort of how we think about it. So for state employees that make $50,000 a year below, it's $176 a month more, which your 3% increase is more than $1.76 a month. And I understand inflation and a lot of other things are going on as well. So I'm not trying to minimize that. And on the high end for individual coverage, it was $8.06.
So not 5% of your salary, which
that's
is what
right.
a lot of people are.
And that's why we're trying really hard, I think, to change the language. Let's move away from the percentage and like the dollars that you are spending on healthcare that are different. Because when I sit down and balance my checking account, I'm not doing like, oh, I have 6% money.
Exactly.
Like I have this much going out and this much coming in, and trying to think about it that way. No number up is going to make anyone happy, but our job is to make it less confusing where we can and kind of be transparent on the totality of the cost impact. I think Kim Jones, one of our board members, brought up a really good point. Even for folks in the access tier, if you had to see one specialist next year, and a lot of folks are, they see a primary care provider, they kind of see the thing.
Mhm.
Because of the reduction to the specialist copay, you will pay less, all things being equal in 2027 than 2026. The preferred tier is like sort of an easy one because it's like half. And it's hard to think about the total cost of healthcare because premiums are a number you see. It's very tangible. And we need to do a better job. I need to do a better job of thinking about the total cost of healthcare and wallet, right? Because your wallet doesn't care if it's your premium or a
Right.
$1,000 bill. It cares about, I got this much going out.
Chipping away at it.
Yeah. So we're going to try to do a better job of thinking about the totality of things. And again, any number up, I appreciate, is not what anyone's looking to do because everything else is going up. And that's why when we think about benefit design, that's an area we can impact to make it go down because I can impact the prices of healthcare. And I think we've demonstrated that a couple of years in a row. Like, we're going to keep fighting to push that number down on y'all's behalf.
Because literally half the workforce was working during the time, which was no premium.
Yeah.
That was the standard.
Yep.
And the idea was that you make less as a state employee, and because of that, your benefits would be superior.
Mm-hmm.
I mean, we've ditched that a long time ago.
I disagree with that. The health plan continues to be a very good benefit, maybe less good than it was. I'll take that point. But if you do any comparison to folks who get commercial insurance, the average premium in the state is $185 for a single member. And at our median premium is something like $50 all in.
But the average wage is not what
I understand
are making.
And 50 is more than zero. Of course, that's true.
Yeah.
But at 1/3 of the cost relative to commercial insurance, it continues to be a very good deal. It's not as good as it may once have been, but I don't want to lose sight of that. There is a good deal embedded in the state health plan still.
Yeah. Before we get too far away from the tiers, because this is a question that I got a lot. So which one of those tiers is the equivalent to the 70-30 or the 80-20?
Access. So the access tier, and this is a couple.
There is confusion over that.
Totally.
There is.
Totally.
And I've just been like,
I think that's a
like they're not
fair.
even a thing anymore.
Yeah,
we have these tiers
right.
now.
So the access tier is exactly the 80-20 and 70-30 from last year, but for the specialist copay is cheaper.
Got it.
Gotcha.
And one other difference that I think is a positive difference, no one in life gets to decide where an emergency happens.
Right.
So there is no non-preferred for the emergency tier and the inpatient stay that comes with it. Right? If you're having a heart attack, go to the nearest hospital.
That's great.
We're not going to penalize you for that. That's irresponsible. So that is the other difference. But if you thought about what is the benefit I have today, it is that access tier because it's where most of the doctors are and where most of the folks access their care.
Yeah. Thank you for that clarification.
Along those same lines, and I don't know if this is a good question or not, but are any providers in North Carolina considered out of network for the state health plan?
So no one new is out of network, right?
Okay.
If you are going to see those providers today, we haven't taken anyone out of the network. No one has told me they're opting out of the network. Some folks are out of the network right now, and none of them are hospitals. None of them are ambulatory surgery centers. There's some primary care doctors that do direct primary care. Or they've elected to stop taking insurance. But that's agnostic of the changes we're making here today. So no one has gone out of network.
I guess that's what I'm getting at, that this change hasn't knocked anyone out of network. And
no, we are not. Our goal is not to take anyone out of network in these plans.
And that was kind of tagged on to the which one's the 70-30 and which one's the 80-20 and, am I still in network?
Yeah. So let's go to the action taken Friday that some of our members are very excited about. You are changing from Aetna to the Blue Cross Blue Shield of North Carolina as the third-party administrator.
And pharmacy benefit manager.
And pharmacy. And I guess CVS was CVS Caremark was the first.
Mm-hmm.
So, and that'll be in January of 2028.
That's a really important distinguishing. Preferred providers 2027 expansion. Blue Cross is coming back as a third-party administrator and pharmacy benefit manager in 2028.
Because it takes you a very long time to set that up.
It's a lot of doing. Caroline told me it's not enough time, but
goodness.
Yeah, we'll be good and we'll do very well. I think we have a great team up to it that is very eager. I think Blue Cross is very eager.
So I'll admit that I'm not watching it as closely as maybe Suzanne is, the health plan, but the last I heard from you, there was nobody submitted a
No, yeah.
proposal.
So
how did this?
Yeah, so we try to follow procurement laws pretty tightly, and for the TPA, 3 folks submitted a bid, none of them met minimum
Right.
requirements.
Okay.
And a lot of that is administrative goofiness, I'll say, by all 3. You forget some forms and you forget some things like that. So we went back out the following week and we had 2 people meet minimum requirements, and then we were able to go. So the process was delayed 6 or 7 days, I want to say, but in the aggregate,
Okay.
that was, where we got some folks with pretty sharp pencils for I's and T's over there. And so we were able to get to the same place. It was just a week later.
I think, Treasurer Briner, one of the times that you were on our show or podcast, we had talked about CVS Caremark, and there was a kind of a dispute with them. Do you foresee a similar thing with Blue Cross, or do you feel better about?
So, and I'll ask Tom to add some detail here, but we went out for a very different PBM relationship this time.
Mhm.
And, I think people typically think of the 3 big PBMs out there, and you'll note that Blue Cross is none of them. And there's a reason for that. We're looking for a fundamentally different relationship. The way that often PBM relationships work is opacity hides profitability, and you can't see that as the payer. And we weren't going to put up with that anymore. So we wanted something different. We asked for something different. We're going to get something different, is how I'd say it.
Yeah, I think that's right. So, we've all talked about this. The big PBMs have shell corporations that are here, and a little bit of money comes out there, and a little bit of money comes out there. We intentionally delineated who's processing the claims versus who's doing the rebates and who's doing the specialty management to who's doing the mails. So they're all trying to do the best at their specific jobs, not figuring out, shave a couple cents off here. And Blue Cross is bringing that all together on the, as a fiduciary partner of the state health plan so that we have better kind of protections and alignment. And it is a very different way of thinking about things. But I am really excited about us having better confidence in where our money is going, and more transparency, insight into where our money is going, and letting people just focus what they're like. A lot of these companies do really good work. We just want you to just do that thing really, really well. Don't worry about that other mess and $5 here or $3 there, having a company in Ireland and then having another company somewhere else. Like, just do this. Just make sure there's a great benefit for state employees.
So we've hopped around a lot on these questions. So
Yeah.
let's just go for it, whatever else.
Yeah. And I'm just kind of asking basic questions today because I've been hit with a lot of them
Mhm.
lately. I also think folks were excited to hear that Blue Cross Blue Shield is coming back, but a lot of people don't understand that a Blue Cross Blue Shield policy is a completely different thing than the state health plan.
Totally.
That the third party administrator handles the paperwork, the
Mhm.
claims, that kind of thing when we use their network.
Mm-hmm. You got it
But
perfect.
but the state health plan designs its own
Yeah.
benefits, so
And
it's
negotiates
not
our own
an
contracts
actual.
and stuff.
Yeah.
Yeah, so they're going to process our claims. We're going to leverage their scale like they can leverage our
Right.
scale. We're going to leverage their kind of North Carolina-ness. And, I think, they're excited to learn from their mistakes and move forward on something that is truly a benefit to
Yeah.
teachers and state employees.
So retirees have been concerned about how this will affect them. And, we've been trying to explain to them that, you're a Humana retiree. This doesn't have anything to do with you. There were some changes
Mhm.
to Humana. They were not premium increases. There were some benefit costs that changed within their plan, but their premiums didn't go up. And maybe touch on
Yeah.
how this does not affect them.
Yeah. Well, so take one step back. After the last board meeting, I got a call from you, and you're like, "What the heck's going on with this rate going up to 6?" And I was like, "That didn't happen." And I was like, I could totally see how that message was lost. So thank you. I was actually driving to pick up my kids from school. And I was like, "Oh boy!" And then Loretta came over and shot a video in my front yard. So the preferred provider program is not part of the Humana benefit.
Right.
The benefit you have with the plan design changes is what you're going to have. There's no provider tiering, and it's still a broad PPO. And that is because Medicare rates function a little bit differently than commercial rates, and our ability to influence those rates is much lower because they're more federally set. Like the federal Medicare Advantage program is sort of what it is. I'm sure they'd like my opinions. I don't think they're going to take them.
Mhm.
They'd listen.
So that will look different. If folks in the 70/30 plan, they are generally on that plan for prescription drugs. That benefit is going to look like what it is today. They can save some money by going to preferred providers. in the 70-30 plan. It's not going to be a lot because, we are the third kind of, or second or third payer, depending on that kind of construct there. But for folks in the Humana plan, there's no change to the network or no change to the approach to the network.
And the non-Medicare retirees fall into?
That's a great question. That is kind of everything we talked about before applies to them, right? The preferred tier, the access tier, and the non-preferred tier does directly relate to the non-Medicare retirees.
Thank you.
So, Thomas, I know that a tremendous amount of work of your staff, your entire staff had to go into this. I can't even imagine how much work went into trying to even construct this. What's next? How long do you go once it's implemented before you decide, is this work?
Yeah, that's a really good question. So I am very passionate about, we can't make these dramatic changes. 1 year's this, 1 year's that. Like, our members are people, not cattle. We have to give them continuity and consistency of things. So, I think about thinking about these contracts every 5 years or so, but if they're working and people are happy and saving money and we're able to invest in their health, I'm not inclined to make a giant change to save 1 or 2% more money. If people are getting the healthcare they need and somewhere they're happy and stations, I don't foresee this system changes being something we will process it and make sure it's working, right? Like, make sure we're saving the money and the math is mathing on all of those things. But I think where we're going next is, I think, a couple of things. And we had a really good consumer segmentation study about what our members value. And about 50% of the members said they wanted plans with richer cost-sharing benefits, lower copays, lower deductibles. And about 50% of them more preferred lower premium plans with more kind of benefits attached to it, like kind of a little bit different look and feel of things. So I think our job is to come up with, given we have these better rates with a lot of systems, can we come up with an additional plan to put aside these that's a lower premium plan that has more flexibility for different members who want to do different things? I think the answer is yes, we can. I think we got to figure out what that needs to look like. So it's, one, attractive, maybe a little simpler, but allows people, maybe they want to save for healthcare, like healthcare retirement or something. Like, people are going to want different things, right? That kind of 50-50 split.
Right.
So I think we need to figure out what is a plan design that is intentionally kind of targeted at lowering premium, like a lower premium product, which is something I think we can do. I think we just kind of have to go through the implementations and then kind of get to that for 2028 is something we're thinking about. And I guess the other thing is next is circling back to something I said. How do we get more preferred providers in rural communities?
Yeah, and what can members do? They want to have a voice.
Yeah.
So how can they help? Can they help you do this?
Yeah, I think they definitely can. I think it is, the more members who use preferred providers, the more leverage and strength we have. The less people use non-preferred providers, the more strength we have. We can show that we're serious. State employees are good shoppers. They're smart people. The more we can show we understand what we're doing and we can leverage those things, we will get better savings. We will get deeper discounts. We will continue to move the ball forward on things. I would love to hear from members what areas they would like to see kind of focused. And I think part of our consumer segmentation study, which, as Beth mentioned, broke the internet for a day. We had so many responses. Continuing to say, like, where we need to keep moving towards, I think, is really, really helpful feedback. And just, and kind of knowing, like, I'm ready to dance with any partner. If the partner doesn't want to dance with me, though,
right,
there's only so far we can go. Yeah.
So I just have 3 quick questions.
Go for it.
Just kind of clean up here. So first off, if a non-preferred provider decides they want to be a preferred provider, is that possible? Like, are you still...
Good question. From a health systems perspective, no. So part of this is kind of going back to the church, but it's a competition, right? And how the preferred providers are able to afford, from a systems point of view, are able to give the discounts they're able to give is because they're going to get more volume. That's the investment.
Oh, so it's set in stone for
the health systems, that it is Novant and UNC.
A year, or?
I would like it'd be this way for 5 years.
5 years.
So our members have assurances, like, if we build a relationship with these providers, we're going to continue to save money because they've invested in us.
Well, wait a minute. If somebody's living in Charlotte listening to this, I already know what they're going to get on our Facebook page and say, well, wait a minute. What if Atrium came around and saw the light? And it would be easier for these folks to find somebody, obviously.
I appreciate everyone's individual concerns.
Yeah.
We are trying to look at
for the whole
all
plan.
750,000 people.
Fair enough.
And it might be easier for that individual, but I want to circle back to one thing about individuals. if you're having a baby, if your baby's in the NICU, if you have cancer, if you're waiting for a transplant or you have some rare condition, we have broad benefit exceptions that we are going to be very generous with and intentional with to keep people with their providers when they're undergoing really complex treatment.
Yeah.
If you're if you're at Atrium for cancer treatment right now, you are not going to be paying a non-preferred benefit in 2027. We will have information coming on how like your benefit will stay, kind of going back to what's the 70-30, what's the 80-20. It will retain the benefit you have today while you're in active treatment for care. We're not asking you to be like, hey, I know your baby's in the NICU right now, but them's the breaks. You got to pay more. It's going to be the benefit you have today.
Nobody's going to be left in charge when it's serious.
Yeah. And so, I think I appreciate there's going to be some FOMO for folks, and I am willing to understand and entertain if folks want to get out of the non-preferred tier and get into the access tier. I'm happy to have that conversation and figure out math that works for everybody. But if there's a winner, there's going to be a loser. It is just the reality of business, I think, right? Like only one person can win your business.
Right.
And so, yeah, I think and I think Atrium is a great health system, but they said our focus is on treating everyone. The other folks said our focus is on treating state employees. And again, I got to dance with who wants to dance with me.
Right.
Fair enough.
And you answered one of my other questions, but I just want to, I guess, finally turn to Treasurer Briner. You did mention the $507 million shortfall when you came in. With all these changes and everything from last year, where do we sit now, and how do you see it moving forward?
Yeah, it's truly been a team effort. And we've seen everyone do their part. So that $507 million is an artifact of history at this point. So credit to Tom and his team, and credit to all the employees who've invested more through premiums, to the legislature, to everybody who got that done. It was $1.2 billion for the following year, and we're almost done with that too. With these changes, if they work out the way that we think, we're on to worrying about 2029. We're never going to not worry about this future of the state health plan. The deck is stacked against you as a healthcare consumer. And so we're going to keep pushing, and we're going to keep pushing those dates out, but we can't stop pushing.
In terms of sustainability, that we're in a much better place now.
Place. We're in a much better place. We've got the basic recipe in place that we think will age really well, and we can push that out indefinitely.
Well, you have, and I've always said it, you have the hardest job in state government. The treasurer is the hardest job. It is the most stuff. It is stuff that dwarfs the size of the entire state budget. It's the hardest to solve.
And it matters to so many people.
It does.
And it's amazing how many people don't know it matters to them. But we have a great team who is doing a lot of good work across all 7 of our divisions. We talk a lot about the state health plan because it's front and center for people, but we touch your lives in a lot of different ways too. And I'm just proud of my team's results.
Yeah, you got great people. And Thomas is coming to, for all of you listening out there, is coming to have some conversation with our board this week. And he's also, as he said, open to, making some trips to speak to smaller groups. I know we had talked about that before.
I will be wherever you want to be. If it's in person or webinars,
my
job is to be where you tell me to be.
I assume someone will be at our convention as well, right?
Yeah,
Thomas
sure.
is. Oh, and okay.
You're stuck with me.
Well, we got the big gun.
Yeah.
No offense, Tom.
I'll be there too. He's speaking first. I think I'm second.
Oh, okay. Well, thank you so much for coming in, and you've always been very open with us and willing to engage. So thank you very much.
We appreciate your partnership. We so much of what we need and want to do involves engagement. And you guys are fantastic in helping state employees have a voice back to us and vice versa. So we really appreciate the partnership. We couldn't do it without you.
Thank you.
Thank you.
Thanks, Sean.
Thank you for joining us for this week's edition of the Scenic View podcast. I thought it was a great conversation with State Treasurer Brad Briner and also Thomas Friedman from the State Health Plan. This is a very complicated issue, so please stay tuned to our website, scenic.org, and our Facebook page. We'll keep you updated and informed on what changes are coming. Thank you.